Afferent and efferent loop syndromes, pathophysiology and clinical features. Welcome to the Everything Surgery podcast, where today we delve into two important mechanical complications that can arise following gastrojejunostomy procedures, such as Bilro-2 or Roux-en-Y reconstructions. We are focusing on afferent loop syndrome and efferent loop syndrome, each characterized by either partial or complete obstruction of intestinal loops, and each presenting with distinct clinical features. Afferent loop syndrome, causes, mechanisms, and features. Let us begin with afferent loop syndrome. This condition results from an obstruction of the afferent limb, the segment of intestine stretching from the duodenal stump to the jejunum. The most frequent cause is adhesions, though internal hernias, stomal narrowing or twisting, and recurrent malignancies such as pancreatic cancer can also be implicated. Pathophysiologically, when the afferent limb is blocked, bile, pancreatic secretions, and duodenal fluids accumulate. This leads to increasing pressure and distension of the intestinal segment. Over time, bacterial overgrowth can occur, which may provoke bile reflux gastritis. The clinical features are distinctive. Patients typically experience pain in the right upper quadrant after eating, which is often relieved by vomiting bile. If the obstruction is near the ampulla of Vater, jaundice may also develop. Malabsorption is common, leading to symptoms such as fatty stools and vitamin B12 deficiency. Acute pancreatitis, although rare, can arise if the pancreatic duct is involved. Diagnostic evaluation begins with imaging. Computed tomography and magnetic resonance imaging often reveal a dilated afferent loop filled with fluid or air. An upper gastrointestinal series may demonstrate that contrast fails to enter the afferent limb. Endoscopy can confirm obstruction at the surgical anastomosis. Management of afferent loop syndrome primarily involves surgical revision, such as converting the anatomy to a Roux-en-Y configuration or performing adhesiolysis. For patients suffering from malignancy, stent placement can provide palliative relief. Efferent loop syndrome, causes, mechanisms, and features. Turning now to efferent loop syndrome. This complication involves an obstruction of the efferent limb, which carries contents from the jejunum to the distal gastrointestinal tract. Once again, adhesions can be a culprit, but anastomotic strictures, volvulus, or internal hernias may also result in blockage. Here, food and digestive secretions build up in the proximal stomach and intestine, causing distension and delayed gastric emptying. Unlike afferent loop syndrome, bile reflux is not a feature, as the efferent limb drains in a normal fashion unless the obstruction is persistent. The clinical presentation includes abdominal distension after meals, as well as nausea or vomiting that is typically not bilious. Chronic cases may lead to weight loss and malnutrition. Diagnosis relies on imaging, with computed tomography scans revealing a distended efferent limb and stomach. Gastric emptying studies demonstrate delayed passage of contents. Endoscopy may identify strictures or twisting at the surgical site. Treatment for efferent loop syndrome includes endoscopic balloon dilation for strictures, while definitive correction of mechanical obstruction requires surgery. Comparing the two syndromes. So, what sets these two conditions apart? The obstructed segment in afferent loop syndrome is the pathway from the duodenum to the jejunum, while in efferent loop syndrome, the blockage occurs from the jejunum to the distal bowel. Vomiting in afferent loop syndrome is typically bilious and relieves pain, whereas vomiting in efferent loop syndrome is non-bilious. Right upper quadrant pain after eating is more common in afferent loop syndrome, while bloating and epigastric discomfort predominate in efferent loop syndrome. Malabsorption is a frequent finding in afferent loop syndrome due to the lack of bile, but is less common in efferent loop syndrome. Acute complications such as pancreatitis and cholangitis are seen with afferent loop syndrome, while efferent loop syndrome rarely leads to bowel ischemia. Clinical pearls and conclusion. In summary, afferent loop syndrome tends to be more severe because it can result in pancreatocapillary obstruction. Efferent loop syndrome is often chronic and may mimic delayed gastric emptying. For both conditions, computed tomography is the preferred initial imaging modality. Surgery remains the definitive solution for mechanical obstructions. Prompt recognition of both syndromes is critical in preventing complications, including perforation and malnutrition. While afferent loop syndrome may constitute a surgical emergency if complete obstruction occurs, selected cases of efferent loop syndrome may be managed endoscopically. Thank you for joining this podcast as we explored these important post-operative complications. Stay tuned for more in-depth medical discussions and practical clinical insights on the Everything Surgery podcast. Dissect the extraordinary.